Good morning. Welcome to the Department of Medicine Grand Rounds. I want to celebrate Laura Brown. Is Laura Brown here? Tell Laura Brown that we mention her name here all the time, but it's because she just sent me a note that her work has been recently accepted at the Northwestern Cardiovascular Young Investigators Forum for discussion, which apparently is quite prestigious, and Dr. Boley told me it's quite a big thing. So if you see Laurel, just congratulate her. I want to have a moment of silence for Gaspar Carawit, who was in the nephrology division for many, many years, and he passed away, I think, last week. And I remember Gaspar sitting back there. Always, you remember him very well. So just a second of silence for Gaspar, who was a tremendous contributor to this organization and a great human being. I also want to take this opportunity to remind you about a few people or events that have changed the way we think about medicine, biology, and humans and behavior in general. And so a few names. Number one is Giovanni Maria Lancici. Giovanni Maria Lancici, who was born on this day back in 1654. He was an Italian clinician anatomist. He was the personal physician for 3 popes. He became a doctor in 1672 when he obtained his MD just 1 month before 18 years of age. He did a lot of anatomical studies and epidemiological studies related to malaria, plague, and influenza. And he wrote a book, which I always like to describe these, even though I don't know what it means, but he wrote a book called De Motu Cordis Mortibus. And it was a very nice treatise about the causes, usually cardiac causes, of sudden death. Number 2, I want to remind you about Gertie Corey. Many of you know about Carl Ferdinand Corey, who with Dr. Hosey discovered the catalytic conversion of glycogen, the Corey cycle. They won the Nobel Prize for that in 1947. What many people forget is that the third person in that Nobel Prize was his wife, who was a very strong researcher and biochemist on her own. And in fact, I believe that she was the third female to win the Nobel Prize after Madame Curie and her daughter, Irene Curie. They were Czech-American biochemists who fell in love during medical school in Prague and moved to the States in 1920 and became citizens in 1928. And finally, I want to remind you about Hans Walter Kosterlitz. Don't make me say that again, with a K, Walter Kosterlitz. And I mention this because today you may hear Mr. Trump talking about the opiate epidemic. And so we remember Hans. Why? Because, number one, he was born in 1903, but he died on this day back in 1996 at age 93. He was a German-born British pharmacologist who worked for many years at the University of Aberdeen in Scotland. And after he retired, he partnered with John Hughes and began studying what happens to the brain during pain. And he discovered enkephalins, who is the naturally occurring opiates in the body. And so that sort of began to open a new window into our understanding of how the human brain reacts to pain and other stimuli, which is an important part of our understanding of the opiate epidemic today. And with that, I'm going to introduce you our speaker of the day, Dr. Julio Ramirez. Many of you, all of you, should know Julio. Julio is originally from La Plata, Argentina. Who am I kidding? La Plata, Argentina. He did his fellowship at the National Institute of Respiratory Diseases and Thoracic Surgery, fellowship in critical care. Rodrigo, I don't know what happened, that he moved from critical care to infectious diseases. He came to the States at New York Medical College, so he did residency in internal medicine again, and he came to the University of Louisville, where he finished his fellowship in infectious diseases in 1989, rose through the ranks to become professor and also division chief in 1995. This organization had witnessed the evolution of a Latin American migrating to this country and becoming a superstar who's been funded by the CDC, the Department of Defense, the NIH, has been a member of important committees at the ATS developing national guidelines for the management of pneumonia, has been part of the Food and Drug Administration in dealing with the identification or decision-making about new antibiotics. He's written over 200 articles in the literature. He's the editor for a new journal that he himself and his group established, and he's doing tremendous work here related to global health, refugee health, HIV infection, and of course, pneumonia. And with that, I leave you Dr. Julio Ramirez, who's going to talk to you about that very topic.
Thank you. Thank you very much. And today I'm going to give you an overview of what we're doing in pneumonia lately here at the University of Louisville. And this is based on a study that we call now the University of Louisville Pneumonia Study. I'm going to discuss a little bit of incidence epidemiology, early mortality, late mortality, and then discuss what we plan to do in future research in the coming years in the topic. To put our, this University of Louisville Pneumonia Study is a multi-center study with all the 9 hospitals here in Louisville. And this is a culmination of our work interacting with different hospitals. That this work probably started in the year 2000 when the community-acquired pneumonia organization was created. As Dr. Roman alluded, this came from the American Thoracic Society that put together a national committee for guidelines of community-acquired pneumonia. I was part of that committee, and this group, I may say, before the year 2000, in the 90s, we all have small studies of pneumonia, 200, 300 patients, we were all able to publish, but now it became clear that you needed to develop networks, a large number of patients, if you were going to really make an impact on pneumonia. Then the Community-Acquired Pneumonia Organization with the CAPO International Study. You've seen this before. At this moment, there are 35 countries in the CAPO study, more than 10,000 patients. And at the University of Louisville, we have the Clinical Coordinator Center for this international study. In our website, the study is still going on. People can join the organization, contribute data, or request analysis of our CAPO database. Now, in CAPO, during the years, we've been working with 2 hospitals in Louisville, our University of Louisville Hospital and the VA Hospital, enrolling all patients with pneumonia into the database. Then we moved, when we were funded by Homeland Security for this study years ago, this was a study looking at, it was a surveillance of influenza. We had 3 hospitals in Louisville and several hospitals across the state in Kentucky. And then really it was the study with the CDC years ago that we started working with the 9 hospitals in Louisville during 3 consecutive years during the influenza season. Then in this particular trial, patients were randomized. You were admitted to the hospital during the winter time. You were randomized to empiric oseltamivir versus a standard of practice. And then we did 3 winters in the 9 hospitals in Louisville. The CDC was very instrumental for us to be able to collaborate among all the adult hospitals in Louisville. And this then brings us to the culmination of our workup, that is the University of Louisville Pneumonia Study, that we work now with the 9 adult hospitals, and this study was a population-based study for 2 consecutive years. Then for 2 consecutive years, any person in the city of Louisville hospitalized in any of the 9 hospitals, we are going to be looking to see if the patient has pneumonia. In the city of Louisville, there are 587,000 adults. Everybody goes to the 9 hospitals, and we did this study for 2 years. Then, to put things in perspective, there's only one prior study in the United States that is population-based, and a study done in Ohio, published in 1997. And of course, because to have a full city or a full county that you count every hospitalized patient is an extremely difficult operation. Then everybody control 1 hospital, 2 hospitals, but it's very difficult to enroll patients in every hospital in a particular city. And this is what we did in our study. There was a population-based cohort study, the total population of residents in the city of Louisville. Any person admitted to the 9 hospitals will look for a pulmonary infiltrate, the presence of cough, fever, leukocytosis, And at the time of diagnosis, the patient is not supposed to have an alternative diagnosis other than pneumonia that may explain the pulmonary infiltration or the signs and symptoms. The study started June 1st, 2014, went all the way to May 31st, 2016. These were the 2 years of the study. The patients were followed during hospitalization, 30 days after hospitalization, 6 months, and 1 year after hospitalization. Then the study was 2 years with 1 year follow-up. There were 3 years of the study itself. And essentially, during these 2 years in the city of Louisville, they will work with the 9 hospitals, and in 2 years, there were 186,000 hospitalizations in Louisville for the 2 years of the study. And we noticed that is more or less a stable number, a little more than 90,000 residents get hospitalized in any of the 9 adult hospitals. Then how do we handle 186,000 hospitalizations in 2 years? Then our daily operation, if I were to say, I go back, let's say in the middle of the 2015, this was one day, one morning in the Med Center 1. These are all cubicles. This is just an idea that people were arriving in Med Center 1 very early in the morning. We were connected to all the 9 electronic medical records in Med Center 1 with all the computers, and we were to review all the hospitalization from the day before in every hospital in Louisville to do the screening of the patients. If the screening tell us that the patient, that the signs and symptoms were compatible with pneumonia, then at that point in the morning, there was a decision how many research associates needs to drive to every hospital. We needed to evaluate 5 patients Jewish, 10 patients Baptist. Then every morning, people work directly to different hospitals. We're doing 3 different studies of pneumonia at the same time. And today I discussed one study, the University of Louisville pneumonia study. But then patients were consenting. We were getting urine samples from every patient. The research associates were returning here to the CTR building. We have the urines were processes, and we have the freezers there that we are squeezing in Dr. Roman's laboratory, CAPO freezers, and then we developed our biorepository of pneumonia for these 2 years. Then this was the daily operation for this study. Another thing that happened is that, as you know, we have a group that is doing informatics and statistics, and the question was, how can we make better our clinical research operation? As part of this, there were a couple of publications for the group. Now this group is led by Bill Mattingly, our faculty member, but Bill put together this article that we put together an application that everybody was having in the cell phone. This is a figure from the article. And this application, you were arriving to the hospital, you select the hospital, select the patient, this information was entered there, and automatically we have a dashboard that was populated with, it's not clear here, but these are the different hospitals, how many patients were candidates, how many patients screened, how many patients were enrolled, and in what pneumonia study the patient had been enrolled. It was a real-time data visualization. At the same time, by the end of the day, this is a screenshot of my computer emails. This is January 2016. Every day, you were getting an email, different members of the team, that you have all the patients eligible and how many patients were enrolled. And every day I was getting, for instance, this would be, again, January 2016, there were 8,000 patients enrolled in the HAPI study, one of our pneumonia study, 9,000 patients in the UAD study. There were 20,000 consent forms. I mean, this was beyond everything that we have done, and probably we are convinced the largest pneumonia study done in the U.S. And with all the characteristics of having these patients in the 9 hospitals with different electronic medical records. Now, looking at the participants, if we do the flow chart of the study, the first year, 93,000 patients were hospitalized in Louisville. 13,000 meet the screening criteria compatible with pneumonia. 6,566 patients meet criteria for pneumonia. And I think that because this was a population-based study, we have the social security number for each patient. At the same time, we have also the address for each patient. Because the only patient that needs to be enrolled in the study is you were living in Louisville, in the city of Louisville. Because the census gives us a population of 186,000 if you are inside of the borders of the city of Louisville. Then the exclusion criteria, here we have more than 1,000 patients that were from outside of Louisville. There's a lot of people that are coming from outside of Louisville to receive medical care in any one of our 9 adult hospitals. As always, there were some patients with social security number that didn't exist and some other reasons to be excluded. We ended with 4,200 adult hospitals with CAP. But then another thing is that you want to count the incidence, you need to count one person at a time. And then looking at the social security number, we figure out if this patient was admitted for pneumonia, let's say 9 months ago. Because then you are not supposed to be counted twice. Then a single patient hospitalized, we ended with the number, 3,700 this year. And we did the same for the second year of the study. And again, the patient will follow for 1 year. Now, this brings it then to the point of the incidence. Then, how common is hospitalization for community-acquired pneumonia in the United States? As I mentioned, there was only one population-based study in 1997, a long time ago. And you go to the CDC website to look at what is the number. The CDC considered that there are more or less 1.1 million patients hospitalized with community-acquired pneumonia in the U.S., and all this is based on discharge diagnostic categories, ICD-9, and that's going to be ICD-10. Then, this is how do we do a lot of things for medicine. Based on ICD-9, we count how many cases. But we also recognize that ICD-9 is all this administrative data is primarily there for billing purposes. It's not for research purposes. But this is the best that we have. But with this number in mind, then we ended in the population of Louisville, 587,000 adults, 3,725 were hospitalized with community-acquired pneumonia every year. And then we can have the incidence, having these two numbers, and this is 349 patients per 100,000 population. Then we have the incidence of hospitalization due to community-acquired pneumonia is 349 per 100,000. Then once you have the incidence with a population base, you can extrapolate the number to the adult population in the United States. Of course, here the big extrapolation is that Louisville has to represent the U.S. Of course, there's no city that represents the U.S., but we have data indicated that the percentage of elderly in Louisville, the percentage of, several characteristics of our census is compatible with Louisville and the U.S. Then this gives us a total of almost 1.6 million patients hospitalized with community-acquired pneumonia in the U.S. based on this population-based study. Another thing that I mentioned is that several of these patients get hospitalized more than once. And the question is, how many patients get hospitalized with community-acquired pneumonia? 1.6 million. But some of these patients, 9% get re-hospitalized during the same year for another episode of community-acquired pneumonia. Then the question is, how many hospitalizations do we have for community-acquired pneumonia? Then the incidence here is 706 cases per 100,000 for hospitalization. And hospitalization, then went there with 1.7 million hospitalizations every year in the United States. Now, all these numbers are critical when you are going to develop strategies for prevention or research or how you're going to allocate your resources. Then this is the data that we have for the incidence. The full population, 349 per 100,000. Now, what is the impact of age? Because we know that in the elderly, the incidence is going to increase when, for pneumonia. The risk of pneumonia increased. Well, in the elderly, more than 65, the incidence is 2,200 per 100,000. 3-4 times the regular incidence for the general population. Now, when we say 100,000, this is simple to say that it's 2% of the population, or 1 in 50. Then if we have 50 individuals in this room more than 65, well, 1 is going to be hospitalized for COVID-acquired pneumonia during the next year. Or your next 50 patients that you have in the clinic, more than 65, 1 is going to be, and we're not saying pneumonia, because pneumonia ambulatory is 5 times hospitalized. This is severe pneumonia enough that you're going to be hospitalized. 1 into 5 elderly is going to be every year hospitalized with COVID-acquired pneumonia. Another thing, we work with members of the health department, and we have data on what are the most common comorbidities in the city of Louisville. Then we know what is our population living with obesity, smoking, diabetes, congestive heart failure, COPD, stroke. Having the population-based data, then we're able to look at the incidence based on comorbidity. And this is another unique thing that we're able to do here. Then go back to adults, 349 per 100,000. Elderly, 2,000 per 100,000. What is the impact of comorbidity? And this is the incidence based on comorbidity. Then what we have here is that we always know that COPD is bad, and with COPD you can get pneumonia. But with COPD, compared with the general population, it's almost 9 times the risk of pneumonia. It's the worst consideration for risk of pneumonia, followed by congestive heart failure, then the elderly, stroke, diabetes, smoking, and obesity. Then this will be the impact of comorbidities on the incidence of COVID-acquired pneumonia based on Louisville data that we then extrapolate to the US. Now this brings me to the third point that I'm going to discuss is that the epidemiology of pneumonia. And we collected a lot of information these 2 years. This is the city of Louisville, and this is according with the census. It's what is called the census tract. Every city in the United States is divided in this census tract. These census tract are areas of the city with more or less 4,000 population with similar socioeconomic characteristics. It will be like a small neighborhood that the census divide. Then, and we have data on the census for each one of these census tracts. As I mentioned, every hospitalized patient with pneumonia, in our database, we have the address of the patient. Then we can pinpoint where the person lives in Louisville. And this is the hospitalized patient. These are the address of the hospitalized patient with COVID-acquired pneumonia in Louisville. These are hospitalization, considering the census tract. Another thing that can be done when you get into this geospatial epidemiology with these fancy computer programs, you can do a heat map because you can do cases per square kilometer with a very low incidence to a very high incidence. And this is the heat map of Louisville when we look at hospitalizations for COVID-acquired pneumonia. And you have seen probably these maps more and more in different articles, in different journals, looking at different risk factors for different diseases. But there's no question there is a hot spot of pneumonia here. And then you can also apply statistics, and in this region of the city, the relative risk for acquired pneumonia is 1.65. Then you have the heat map, you have your statistics. Now, going back to the census tract, when we look at the data from the census in the city of Louisville, we can essentially do heat maps for the census have like 30 different characteristics. Remember when you do the census that you answer 30 different questions. All these questions, we have it for everybody, and we have it for census tract. Then we can do heat map for everything that the census, the information of the census has. And this is based on the patients more than 65. The hot spots are in this part of town. And you can define, for instance, where are the elderly living in the city of Louisville. This has nothing to do with pneumonia. This is just data from the census using geospatial epidemiology. You can also figure out percent adults living in poverty, and you see here 30 to 70%, and these are the areas where we have the poverty areas of census tract in the city of Louisville. Then we have the heat map we have the dots, and you can also superimpose then the dots on top of the different census tract data. These are the dots with the number of the statistical area with the poverty. And this is the best association. This is almost a perfect association of development of pneumonia if you live in an area with low income. There is less association with race, and there is almost no association with the elderly. Then the most important consideration for all this data is the clear association of poverty and pneumonia, and there is a lot of considerations why poverty may be associated with pneumonia. This has to do with the health disparities. That is, again, another big consideration for all the things that we're doing in medicine. But socioeconomic status contribute to an individual risk for developing pneumonia. This is important for prevention. This is important for interventions. But this also is, for us that we're doing research, this is also very important from the research perspective, because poverty is associated with the incidence, associated with some of the outcomes. And it's interesting. We have never, this is an important confounder in patients with pneumonia. That may be an important confounder for a lot of things that we're doing. That we'll be looking at outcomes of different diseases, and these will never adjust for socioeconomic status. Then here we have a confounder that in all our multivariate analysis we never consider. Then this is, even from the research perspective, is a new challenge that will need to be adjusting in the future. Okay, let me move to mortality and early mortality. Go back to the CDC. This is, you say, okay, what happened with mortality? Everybody has, whenever you read an article on community-acquired pneumonia is the #1 cause of infectious death in the United States, and community-acquired pneumonia is the 8th leading cause of death. Everybody knows this because this is what the CDC tells us. Okay, when you look at the cause of death, pneumonia is there, number 8. And pneumonia is there because there are 56,000 deaths every year. And all these numbers are coming from the death certificate. Then we already proved the CDC wrong regarding the number of cases of pneumonia hospitalized. And now we're going to prove the CDC wrong regarding the number of deaths in the United States. Let me show you the data. Then this is the way that we look at the clinical course when the patient gets admitted with pneumonia. You either improve, you either fail, or you have non-resolving pneumonia. When we look at the failure, we started this during the 90s, and this was all our data on clinical improvement, IV to oral switch therapy in pneumonia. But now we are more interested in this group. And here, we have an article in Chess some time ago, primarily the etiology. What happened when the patient failed? Now, the primary etiology is very common. Whenever you fail of an infection, you go into sepsis and you fail. This was not a surprise. What was a surprise for us was the second most common reason for failure in pneumonia, that was acute myocardial infarction. Now, we all recognize that a patient with pneumonia may have an acute MI, but we didn't realize that was so common. That is the second cause of failure. And this has brought now, and this was another article we have in Clinical Infectious Disease, acute myocardial infarction in hospitalized patients with community-acquired pneumonia. And in this propensity score, we see that the pneumonia severity increased, the risk for acute MI also increased. And in this study that we review article put together with Paula, what is the association of cardiovascular events? I think that high level of pro-inflammatory cytokines, this is a consideration, probably endothelial dysfunction, atheroma instability, and rupture of the atheromatous plaque. And now there's a lot of literature of cardiovascular events in patients with community-acquired pneumonia. It's well established. It's one of the risks when you get this, to the point that if your patient with pneumonia fails, yes, you need to repeat the X-ray, look for the empyema, look for the resistant organism, but you need to evaluate cardiovascular status because the failure may be due to a cardiovascular event. But still, until recently, I discharged the patient, I saw the patient in the clinic, 30 days, I repeat the X-ray is normal, and at 30 days, we used to say to the patient, that's it. The pneumonia is resolved, go back to your internist, nothing to be concerned. But this brings me to the point of late mortality in pneumonia. Then, A couple of years ago, we looked at these patients that were discharged from the VA hospital. And these patients were admitted to the VA hospital to internal medicine. And we all take care of these patients with different medical conditions. And we separated patients that were admitted to internal medicine with community-acquired pneumonia, 324, and patients that were admitted for any other medical condition to the medical ward. We followed 6,300 patients for 5 years. And then we have the percentage of patients that survived, the survival, and this was no community-acquired pneumonia, this was community-acquired pneumonia, survival. We have here the 50% of the population dead with community-acquired pneumonia, 50% without community-acquired pneumonia. Of course, you are elderly, you get hospitalized, you're going to die in 1 year, 2 years. But if you have pneumonia, you're going to die earlier compared to the patient without pneumonia. And we published this in CHEST. Then, in our University of Louisville study, we follow the patients, as I mentioned, for 1 year. Then what happened with the mortality at different time points? In-hospital mortality, 30 days, 6 months, 1 year mortality for the patients in Louisville. And this is the percentage mortality that we have at every point. Then move from in-hospital mortality, 6.5%. This is very good because in the past they used to be 10%, 9%, 8%. Then we are definitely doing better in the management of pneumonia when the patient is in the hospital. But then this moved to 13%, 23%, 30%. And this is data very similar to what we look at in patients with pneumonia at our VA hospital in the prior study. And if you look at what happened with these patients for other studies, usually at 1 year, the mortality is around 20%. Then having pneumonia increase your mortality 10, 15% at 1 year. Then we have the mortality for every point, and we know how many patients are going to be hospitalized with community-acquired pneumonia based on our incidence data, based on our population-based study. Then we can estimate the number of deaths in the United States due to pneumonia, and these are the numbers. Now compare this with the 56,000 that the CDC is indicating. Again, another thing that tells us that just looking at a paper, like a death certificate, is not useless, but it's almost useless. Because I did my pilot study here, and I mentioned to a lot of you, I said, the patient is admitted with community-acquired pneumonia. In 3 days, the patient develops a cardiac arrhythmia, goes to the CCU, then develops an acute MI, and dies. What is your cause of death in the death certificate? 100%. Cardiac, acute MI. When the World Health Organization said that the cause of death is the disease that initiated the event. And what initiated the event is community-acquired pneumonia. This is why the patient arrived to the hospital. Then we go back that this 56,000 is completely underestimation because it's based on whatever we write in the death certificate. But it's not the real thing. It's the same that whatever in the ICD-9. We don't even write the ICD-9. It's a person in coding in the basement just figure out, okay, what's going to give me more money? Whatever, COPD exacerbation. Then pneumonia goes number 4. It's never number 1. But these are the numbers, significant numbers. Then essentially, and at 1 year, we have 500,000 patients. Then this number also is an indication that and we're not talking, this is every hospitalized patient with pneumonia. Then for every 3 patients that you're going to see hospitalized with community-acquired pneumonia, 1 is going to be dead in 1 year. Now this number jumps to 50% if the patient is in the unit. And Rodrigo is working with our database looking at severe community-acquired pneumonia because we have also all the community-acquired pneumonia in intensive care, and this number is 50%. Then you have community-acquired pneumonia, and you are in the unit. 1 out of 2 is going to be dead in 1 year. And this, no surprise, is the heat map based on the death at 1 year. Then not only being poor, you get more pneumonia, but also if you develop pneumonia, being poor, there's more chances that you're going to be dead at 1 year. And this brings me to my last point in this presentation, that is the future research. And in future research, as Jesse mentioned, we have a journal, the University of Louisville Journal of Respiratory Infection, and this is issue 4. And these are two things that we published. One is, again, we review all the data for all the articles that are there for long-term mortality in pneumonia. At this moment, there are 15 articles that show this increased mortality in pneumonia. And usually 1 year is around 30, 35%, and without pneumonia is around 20. And if you were not in the hospital in 1 year, if you are an adult, you have less than 5% risk of being dead. Then, for the general population, less than 5%. You were in the hospital is around 20%. But you were in the hospital for pneumonia, your death at 1 year is 30%. Then something happened with pneumonia and long-term mortality. And also, I want to discuss what I put in our journals as an opinion piece on the pneumonia pathogenesis. Then in this article, we made this hypothesis. In a particular, you live in a particular country or a particular region, and you have your life expectancy. Let's say you are 50 and you're supposed to die around 80, then you know that you have another 30 years to live. And then this person developed an episode of COVID-acquired pneumonia. And the person is admitted to the hospital, and we are happy because you survived this 6% mortality in hospital, and you are discharged. Again, as I mentioned before, we used to say, okay, you are discharged, that's it. Pneumonia is an acute problem, everything is solved. And we thought that after discharge, the person is going to keep moving in their same life expectancy. Now, it's clear now that what happened after the person is discharged, you move to a different life expectancy. Because now, you drop all these years of life expectancy. Then the question is why the person moved from here to now. I arrived to the hospital, being a 50 years old, you leave the hospital like a 60 years old. And all this is speculation, okay? And enter an area of hypothesis driven, and this is what we want to look into. This is again future research. I finished whatever is the evidence that we were able to study. Now this is a speculation. And we think that this pneumonia, somehow there's chronic inflammation, and we know that the concept of inflammation and aging, the concept of chronic inflammation, some people call this inflammation. We know that this pneumonia somehow give you chronic inflammation, you have inflammation, and then you have an early mortality compared with your life expectancy before your episode of pneumonia. Another way to look at this, and this early mortality, this inflammation, probably is playing a role here, is all the comorbidities that are already there, because every one of the comorbidities we know today is associated with chronic inflammation. Then probably there is community-acquired pneumonia that somehow feed this inflammation, and then are all these comorbidities that the patient already have before they have pneumonia that get accelerated. Then the person still die of the heart disease, but instead of dying 5 years down the road, now it's dying 3 years down the road. That is an acceleration of heart disease. Now, some patients get re-hospitalized with pneumonia and die for another episode of pneumonia, but the most common reason of death is not another episode of pneumonia. Then we think that this is the early mortality. Now, looking at again, these 2 years data in Louisville, how common is for hospitalized patients with community-acquired pneumonia, for every person in the city of Louisville, is to have comorbidities. This is 12%. The 12% of the population has no comorbidities. And only 10% of patients hospitalized with pneumonia doesn't have comorbidity. 1 comorbidity, 2 comorbidities, 3, 4, and 5 or more comorbidities. A lot of comorbidities in our patients hospitalized with pneumonia. And when we look at mortality at 1 year, we can see that no comorbidity, 1, 2, 3, 4, 5 or more, with a trend that is statistically significant, then there is no question, again, no surprise, the more comorbidities, the more likely that you're going to die at 1 year. And this brings me to the other thing that we are discussing in the issue 4 of our journal, that, by the way, if anyone wants to receive the journal, it's open access, as we just need to have your email, and you get this when we publish. Let's go back to the pneumonia pathogenesis. And anyone in the field, any one of us has been teaching pneumonia to medical students. And the story has been always the same. There is the alveolar space, the alveolar macrophage. The alveolar macrophage, there are more or less 50 alveolar macrophages per alveola, and the alveolar macrophage is very good to maintain the sterility of the alveola. And then somehow, some bacteria arrive, Streptococcus pneumonia arrive to the alveolar, and then the interaction of the pneumococcus and the alveolar macrophage is going to determine that if the macrophage kill the pneumococcus, then essentially nothing happens. If the pneumococcus multiply, the alveolar macrophage is going to produce cytokines, is going to generate a local inflammatory response, and the patient is going to develop neutrophils bringing to the alveolar lymphocytes and the episode of pneumonia. Then we recognize today that all this teaching of pathogenesis was wrong, primarily because we know that the alveolar is not sterile. Then this is the way that the normal alveolar looks. Now there are years of the lung microbiome, and we know that every alveolar is a lot of bacteria, primarily anaerobic bacteria. Some bacteria, free-living, planktonic, but a lot of bacteria attached to cells. And more than this is already proven, but this is the speculation that even some of the bacteria attached to cells may be living in biofilm. Because remember that, again, another thing that we thought that biofilms were only when you have a prosthesis. You need to have a pacemaker, you need to have a new hip, a new knee. Now biofilms happen in our own cells. Then probably there's a lot of biofilms, bacteria living in biofilm in the alveolar space. Then this will be the lung microbiome. And we know that the lung microbiome is composed by bacteria, but there's also the virome, there are viruses, there are fungi, there's a full spectrum. Now, compared with the GI microbiome, the lung microbiome is in the infancy. Okay, we're still learning what to do with the lung microbiome. But I'm sure that it's going to have the same implications that the GI microbiome in health and disease. Then, if the pneumococcus arrive to the lung to produce pneumonia, the point here is that not only the alveolar macrophage is there, the pneumococcus have to deal with the quote-unquote normal flora. And from what we learned from the GI microbiome, we know that the normal flora is part of the immune system, and people are already considering that the lung microbiome is part of our innate immune system in the lung. Then the pneumococcus, we have to figure out how to deal with the normal flora. But there's another consideration for pathogenesis, because we always used to teach that the pathogenesis of pneumonia, the first thing that needs to happen is that bacteria need to arrive to the alveoli. Well, bacteria don't need to arrive to the alveoli. Bacteria are in the alveoli. Then dysregulation of the normal flora, you may have pneumonia due to part of the lung microbiome that is already there. Now, since these bacteria are all anaerobes living in the lung, and we always complain to microbiology that most of the time we cannot define what is the etiology of pneumonia, well, probably some of these patients that we cannot define the etiology is because these are all the anaerobes that are normally in the lung, that some species get out of control and start multiplying and generate pneumonia. There's even the third consideration that people say that this may be a combination. Pneumococcus arrive because the normal flora get disrupted whenever there are changes, whenever there are cytokines. You have bacteria living in biofilm, you have production of cytokine bacteria, the biofilm gets disrupted, bacteria multiply. Then it may be that probably every case of pneumonia is polymicrobial. You may have the pneumococcus coming from outside, but you have multiplication of the normal flora always. If this were to be the case, the patient gets admitted to the hospital, either you fail, you die, but then the person improved. We give the 5-7 days for the pneumococcus because I got the pneumococcus in the blood, susceptible to penicillin, the antimicrobial team. Now you narrow the spectrum, give 7 days of penicillin, everybody's happy, we kill the pneumococcus. But it may be the possibility that we kill the pneumococcus, but the patient remains with a low-level inflammation due to a dysbiosis, due to a dysregulation of the normal lung microbiome. This would be almost like a chronic subclinical pneumonia. And this may be what happened in some patients. This is the hypothesis that we're going to be testing in the future to see if this were to be the case, can we do something for this chronic inflammation? Then it will be the lung driven the chronic inflammation. This is even the consideration if you have a dysregulation of the lung microbiome in the same way that we have translocation in the GI tract. Do we have persistent translocation from the lung into the systemic circulation? All these is things that we need to learn now that we know about the lung microbiome. And essentially, I give you an overview of our pneumonia study, the incidence, epidemiology, early mortality, a little bit of future research. Most of what I explained here today is going to be published probably next month in clinical infectious diseases. Whenever we have our clinical research course, we always mention that from the time that you write the protocol to the time that you get your publication is usually 3 to 4 years. Well, this is going to be 4 years. By December, it's going to be 4 years that we started with the protocol for our pneumonia, University of Louisville pneumonia study population base, because it was essentially 4 years ago. Then this also gives me the opportunity to thank all the investigators that were here at the University of Louisville Pneumonia Study Group that over the years, Dr. Roman had kept signing position for our research associate. What happened in our clinical research group, people moved, the study was 4 years, and this is the group of clinical research associates that the 4 years of the study were moved. These are more than 100 people. It doesn't mean that we have 100 at any given point, but there was 100 over a period of 3-4 years. And some of these people already moving to do residency programs in other institutions. And essentially, how to manage this is another thing that we are proud in the division, is our clinical research coordinator center that have been always supporting research with a lot of members of the department. We have the clinical research operation units with the 9 hospitals I mentioned that every day. This was a 7 days a week operation, no holidays, there was no Christmas, no New Year. This was 2 full years of going to the hospitals to enroll patients. And then a lot of different units these are the director of one of the units, that primarily these units were primarily to support all the 100 research associates that were doing most of the work. And with this, thank you very much for your attention. Thank you.
Julio, thank you. I have a question for you. But before that, you saw all those names on that list. Multiply that times 10, and that tells you the number of signatures I have here. Julio, this is terrific. It takes an enormous amount of energy and coordination to get all these people and get all these numbers and ensure accuracy and so forth. I wanted to bring to the concept, to you, this concept that we know that Kentucky has a higher incidence of a number of things, including tobacco exposure, including obesity, and other issues. Could we, because of that, be overestimating the incidence of pneumonia and mortality because we have more comorbidities? Having said that, you also convinced me that poverty is a critical issue, more perhaps than the comorbidities. Can you talk about that?
Yes, yes. No, it's important because this was a big issue because then we evaluated because there's a big difference between Kentucky and Louisville. And Louisville is not Kentucky. But we have to explain this very thoroughly to every reviewer. Then we have the census data of Louisville and the census data of the U.S. And the smoking is very similar for Louisville. The comorbidities are very similar for Louisville. The only thing is that there are a couple of numbers, of course. But another thing that we did is we look at the census data of Chicago, Nashville, and you look at the big cities in the U.S., we are more comparable with the U.S. than the other big cities. Louisville is more comparable. But Louisville definitely is not Kentucky in this regard, because this was a big issue. Now, Louisville is similar to other cities that poverty is very well divided, and the west part of town is different to the east part of town, then poverty has been the most important association. And I didn't present the data, but when we adjust, race was not a factor, it's poverty. Of course, we all know that race and poverty are interconnected, but race was not a factor. No. Yeah, no. Why COPD is such an increased incidence? That is the most serious condition, and there are we alluded to possibilities. One is that COPD, because of abnormalities in the lung, really the person are more predisposed. Or the other, since we are looking from all the pneumonia spectrum, only the hospitalized, is that a person with COPD always develop serious pneumonia, then every COPD patient ended in the hospital. And I think that it's perfect. I think that, as you mentioned, it's a combination of both. It's a combination of both. Because as we all work at the VA hospital, and you know, you have a person with COPD that is already with oxygen, and the person has pneumonia, every COPD patient is going to have more serious pneumonia than other patients. But at the same time, as you also alluded, the immunity and whatever is going to be with the microbiome of the COPD patients is going to be different. And there's no question that for all other comorbidities, there is a risk. But when the comorbidity is in the lung itself, the risk is much increased. I think that now this story of the lung microbiome, some people suggest that in the past, we used to say there are some studies indicated that we use antibiotics. Antibiotics are bad for so many things, but some patients with antibiotics may be more predisposed to pneumonia. Well, we wonder now if using antibiotics and producing abnormalities in the quote-unquote normal flora may predispose you to pneumonia. This COPD patient keep getting antibiotics regularly. It is also a factor. But the point is that 9 times the normal value is that the basic question here is that we need to go back and see in what person I need to do a program to prevent pneumonia. You know what is the population. It's going to be the COPD patient, or it's going to be what part of town you're going to do the stop smoking, stop drinking, and vaccination. The 3 areas for prevention of pneumonia. Yes? No, yes. No, I agree. I mean, to me, I'm considering that to me, if this idea of the lung microbiome is so relevant, it's going to be relevant, the same that GI microbiome. Then what was the ultimate things that we do for our patient with CD and recurrent CD? Years ago, we started with the fecal transplantation. Then I wonder how are we going to give the normal microbiome in the lung? Is it going to be the bronchoscopy that we're going to wash with the transplantation? This is all, I mean, you can imagine with what we're learning in the GI tract, how things are going to translate into the lung microbiome.
Good luck with that.
Yes, no, this is, of course, this is the, oh, yes. Well, it's the question always, whenever we have an association in medicine, the question is always the chicken or the egg. I mean, what goes first and what goes second? What is causing, this is causing that. Then we have an association of pneumonia and the person that's going to die early. Then the question is, if you're going to die early, you're already in your trajectory to die early, you always develop pneumonia before you die early, then pneumonia is just a marker. Now, you develop pneumonia, then you die early, then pneumonia is the cause. And this is still, no, it's going to be very difficult. What is interesting is, no, study after study, this association is there. This is why the biological plausibility we're trying to develop. I mean, how is that inflammation, chronic inflammation, how is that? And I have to tell you that there are other considerations. The most important consideration, for instance, for pneumococcal pneumonia is that now there is data that you get pneumococcal pneumonia, a significant number of patients, that even though you may have negative blood cultures, the problem with blood cultures is that you put a needle 2 times, but the bacteremia in pneumonia stay there for 10, 15 minutes, then disappear. 4 or 5 hours, 15 minutes. Then you have positive blood cultures or no, if you're lucky enough to put the needle when the patient has bacteremia. The negative blood cultures in infectious diseases doesn't mean a lack of bacteremia, but there's more evidence that you have pneumococcal pneumonia. There's always translocation, there's always bacteremia. Now there's clear evidence that the pneumococcal get into the heart and affect the myocyte. You have microabscesses in the heart during pneumococcal pneumonia. Then then some patients, when you say that the cardiovascular disease deteriorates after pneumonia, it may be some infection. I mean, it may be as simple as you have a bacteria affecting, given the myocarditis that we have not recognized in the past. But since we know that most pneumococcal pneumonia is only 10% of all the pneumonia, then the question is how you explain the others. Then you want to provide the inflammatory process, it may be the best way to explain. All this is future research.
There's a question over there, but before that, there's also a possibility, or a different possibility, that is that you return back to your baseline sensitivity after a number of years that you haven't tested. So if, for example, lung cancer, after someone stops smoking, that higher incidence of lung cancer is still there, probably for over a decade. But at some point, it is thought that you return back to your baseline sensitivity like the regular community. Is it conceivable that you have gone to you dropped to the one line, but after a number of years, if nothing else happens, you might actually recover back to your original line? That's something to think about over time. That will take long-range studies.
No, yes, and also again, all this data of comorbidity. If you don't have comorbidity, that this happened at 1 year versus is this driven by the comorbidities alone? Again, this is all a new area. I mean, having pneumonia as a long-term outcome is a totally new area.
Yeah. Non-hospitalized?
Yes. Oh, how confident I mentioned that probably if you look at all pneumonia, for every 1 pneumonia hospitalized, there are 5 pneumonias that are ambulatory. How confident we are in this data? The level of evidence, 0. It's all expert opinion. Because again, ambulatory community-acquired pneumonia is something that, this is why it's so difficult to study. Imagine you want to do an ambulatory community-acquired pneumonia in the city of Louisville, you have to go to every clinic, and then how you get the x-ray, then all these are estimations. Estimations that 1 hospitalized, 5. Estimation based on a little bit of what happened. You go and do surveys in a clinic, you do surveys in the emergency room, and you figure out how many patients, no, you get the pill, go home versus, but they are all estimations. There is 1 to 5. Well, no, it's very difficult because, for instance, we work with the student health here because we have young people but the problem is that once you have a 20-year-old and you hear crackles, the patient you just treat for pneumonia. The physical exam is enough. You don't get x-rays. But then if you want to publish something without x-rays, it doesn't exist. Then you have the discrepancy of clinical practice, that you know how to diagnose pneumonia in a 20-year-old student. That's probably going to be mycoplasma. You give a macrolide versus doing research that is an area we attempted, but it's very difficult. Yeah, we look at the patient get hospitalized, and there are multiple scores for severity of disease, and then we look at all these scores to see, because we want to try to predict who is going to die at 1 year and do multivariate analysis, because we want, essentially, we want to do a clinical trial. This is what we are doing, a clinical trial. I discussed it, which is that we are going to go to the 9 hospitals, and whenever you are discharged from the hospital, you're going to be randomized to anti-inflammatory therapy or no. This is our idea of the clinical trial. But before you are randomized, the question is, can we enrich the population to see who are the higher risk of death at 1 year? We've not been able to statistically to come out with a model to say that these are the patients at higher risk for mortality at 1 year, except the comorbidities.
Julio, I have a comment that maybe I will have a little difficulty articulating, but let me see if you see this. So you have described a number of morbidities, and yet the most important factor is poverty. In fact, I was impressed that aging wasn't the most important factor, and yet because of our current understanding of biology, the explanations continue to go back to our biological understanding. It is aging, it is inflammation, it's anti-inflammatory agent, because it's difficult to test pathways of how poverty promotes death and pneumonia. Okay? I mean, in a biological sense. And so in the asthma world, for example, there's now an article showing a correlation between stress and an action on a certain polymorphism in one of the epithelial receptors that may be associated with incidence in asthma in societies that have higher stress because they're in war and so forth. And I wonder if we need to pull back a little bit and study biology, but also begin to look for novel pathways by which poverty is linked to other downstream biological events. It's just a comment.
No. I agree. There's a lot of people looking at this, because again, the list of, again, poverty is another marker. It's a marker of 10 different possibilities. And the question is, which one of these 10 possibilities, Tim Wincan is submitted NIH proposal, because we look at now, we because for each one of these areas, now we're going deep. And we are submitted now, he look at the poverty, looking at the deprivation index. The deprivation index is something that you just look at different factors, you get an index, how is your poverty affected. And based on deprivation index, it's very clear that the more deprived you are, the more pneumonia you get and more likely to die. And the question is, would like to submit, but he's now in the School of Public Health, but from the School of Public Health perspective, to try to look at inequalities and what are the factors from this deprivation index, what are the most important factors that are going to make your risk of developing pneumonia or die at 1 year. Then, yes, we need to still understand, because poverty is a bag of things. I mean, what is inside? As you mentioned, is some genetic component, or is a social component, or is a nutritional component? What is that with poverty that is affecting the incidence and the outcomes in patients with pneumonia? Because then this will be the therapy.
So, thank you, Julio. So I'm sure you're all going to go back home thinking about pneumonia differently. Last question.
Thank you very much. Thank you.